Dr. Thilaka Ratnayake. Dr. Thilaka Ratnayake, the consultant psychiatrist from the South Essex Partnership Trust in the UK, giving us a presentation online. These the college lecture presentations, and it's going to be on a very interesting topic today. So thank you very much, Dr. Thilaka Ratnayake, for sacrificing your Sunday afternoon. For us, it's evening. For the College of Psychiatrists to do this very important presentation. And it's going to be on top 10 tips for the psychiatric clinical examination. And mainly he's going to talk to us about the experience of being the external examiner last year in 2021. And to briefly introduce Dr. Thilaka Ratnayake to the audience, now the advantage of having Dr. Thilaka Ratnayake today as the lecturer is that now he has worked as a consultant psychiatrist both in Sri Lanka and in the UK, and he has the MD in psychiatry from Sri Lanka, as well as the fellowship of the Royal College of Psychiatrists UK, and he has been an examiner for the MRC Psych for quite a long time, 15 years. So he has the experience of both the training of Sri Lanka as well as UK, and the examiner and the experience of being an examiner in both countries. So Dr. Thilaka Ratnayake passed his exam, the MD Psychiatry in Sri Lanka in 1992, and he worked as a consultant psychiatrist at the teaching hospital Karapiti for 3 years, General Hospital Matara, and teaching hospital Anuradhapura for 1 year before migrating to the UK in 1998. And he had his overseas training prior to migrating to the UK in Birmingham, UK. And then he obtained his membership of the Royal College of Psychiatrists UK in 1999. And as I already mentioned, Dr. Ratnayake had been an examiner at the MRC Psych exams since 2005 for 15 long years. And his specialty is in medical education, and he has been the director of medical education of the South Essex Partnership Trust for 8 years. And he currently works as the consultant psychiatrist at the South Essex Partnership Trust. And he has a lot of experience in working in the crisis team, the assertive outreach team. And he has also been a visiting professor of the University of Hertfordshire in the UK for 3 years. So as I mentioned, that Dr. Ratnayake has a lot of experience in being an examiner at the MRC Psych exam. And also he was the external examiner for our exam, the MD Psychiatry exam in 2021. And he'll be able to compare the performance in the clinical exam as well as the written exams in both countries. And I think his experience and his comments will be quite valuable for our candidates who are sitting for the exam this year. And thank you very much, Dr. Ratnayake, again, for agreeing to do this very important presentation for our candidates, as well as the examiners. I think examiners also, we can learn a lot from you, because your words of wisdom of being an examiner in both countries will be quite important and beneficial to us. Thank you very much, and over to you, Dr. Ratnayake.
Okay, thank you. Something I've been trying to share the screen.
Sir, Sumudu here. So actually we could see your screens earlier. So now, sir, if you can open the slides, PowerPoint presentation, and then if you can share this share button, you can see the green color, sir. Bottom.
Yeah, no, something has happened to my screen once. Oh, yeah. Yeah, share screen.
Yes.
And then
so have you?
When I put share, how can I put my slides now? Chamara.
Yeah.
I have emailed it to Chamara. Chamara, would you be able to share it?
Yes, sir. Okay.
I have just emailed you.
Okay, I'll check, sir.
So if you can open the PowerPoint presentation,
Okay. In the
okay, and then it will be there, and then you go to this top
Can-
bar below
can you
bottom
say
bar, sir. No, sir. Then you have to go to this bottom bar. Then you can see this share screen button, sir, green color one,
yes.
and then press it. Share
Green
screen
screen,
button.
yeah.
Yeah.
But it won't share this. I'm not that familiar with the Zoom because we usually use Teams.
That will be okay, sir. We can share it.
Wait, I'll share it.
Okay.
Is it okay now?
Yes. Yeah, that's fine.
Okay. When you want me to go down on the slides, just let me know on the.
Oh, thank you. Yeah, okay. Good afternoon, good evening in Sri Lanka, everybody. So I can't see myself now, no? That's okay. You can see me, can you?
Yes, sir.
Yes, sir.
Okay. So first of all, thank you very much for the invitation about this topic, about the regarding the MD psychiatry exam for the candidates who are going to sit the exam. And I'm aware that some of the examiners there as well. So these are my viewpoint. I gather these tips from my own experience by sitting MD exam in Sri Lanka, and also being a sitting MRC psych exam, and then being a CASC examiner for more than 15 years. So when I see the clinical exam, so I think this would help for at least some extent for the candidate not to pass the exam. I would say it as a prevent failing, more or less, because I think all the candidates have the experience of the psychiatry to pass this clinical exam. In my view, the candidate themselves who dig their own graves to fail the exam. So that's why I put these, the points are important, prevent failing. And I'm sure that you are aware what is the benchmark of passing the exam. It is not somebody's vast knowledge of the topic and subject and all these things. It is just to see whether there is a saying here, whether you would choose this candidate as your SPR, specialist registrar, and can you leave this SPR in your ward when you're on holiday to manage the ward. And if there is any complications, whether they can identify it and get the advice from you. So that is the benchmark. So we are looking for somebody who is competent as a good SPR. Because passing MD exam itself doesn't mean that you start straight away practicing as a consultant. You have another 2 years to shape up your behavior, the practice to become a consultant. So the benchmark is that. So in that situation, I don't think it is actually, in my view, it is difficult to fail the exam if you exactly know what you are looking for. So, Chamar, if you go to the next one, I think many candidates, even myself, when I was a candidate myself, we have a confusion what actually they are testing in a clinical exam. During clinical exam, what they test is your skills and competencies, not the knowledge. I mean, the theory knowledge. So you don't need to have a big theory knowledge to pass clinical exam. By the way, if you have any questions or any contribution, please feel free to contribute or ask a question, because we can have an interactive meeting. But I can't see the screen any to put there. I know it's in Teams, hands up or anything. But Chamara, you might be able to see that now. Hello. No, I think you need to. Oh, sorry.
Yeah, I think Sumudhu and Chamara will be able to get the questions to you, because we can see the questions that have been typed by the.
Okay.
Oh, yeah.
But I can't.
Yeah, we can see them. Yes. Yeah.
Okay. All right. So I need to go to the previous slide. Yeah. So it is the theory. There is a big vast difference between theory and the practice. The theory knowledge is already being tested in your theory part, and the clinical exam is very different in that sense. Now, in here, the CASC, as the name implied, it's clinical assessment of skills and competencies. So it is just clinical assessment. What do you mean by clinical assessment? What exactly happening in day-to-day practice in your ward, in your outpatient clinics, wherever it is, whatever the practice area you are doing? That standard is the one what is expecting in exam setting. But when we were not aware about that, what we do is we read a lot and we think that they are expecting a lot, and then we getting ourselves confused. But if you are just focused on your day-to-day clinical practice, and if you can present that one, I think that is the standard pass. So to build up your case in a kind of with a rational argument and only giving the relevant points, clinically relevant points at that particular situation. As an example, some cases, they think that there is lots of things expected, and they try to put a lot of theory into it, which is not relevant in some sense. And the passing exam, as I said, it is the standard practice. But if you've been outstanding, and then of course you can reach the gold medal level. But the thing is, first you need to pass there, go into the passing level. So you need to go from the basics and build up your case. So always remember, it is clinical practice rather than the theory. And where we start practicing for exam, clinical exam, actually that should be the day that you start as a trainee in your ward or wherever your practice area. So in that time onwards, you should think, one day I will get a case like this, and if it is the exam case, how would I do that? And it should be your routine kind of practice, rather than you make a different kind of way to the exam. Because people, we can, as examiners, we can see clearly somebody when they are presenting, whether they are presenting in a very artificial way rather than their natural routine practice. So if you make yourself the standard routine practice in your ward, your practice area, then just replicate in the exam. So now in here in UK, even they have changed. You can sit the clinical exam even without a single paper. Those days you need to sit the papers, paper A, paper B, and then you need to have a clinical experience for 2 years before sitting your the CASC exam. Now it is different. They have changed it. I think it's quite okay to change like that. Now, even without the theory papers, you can sit the clinical exam, because clinical exam is a completely different to the theory settings. So that's what I wanted to highlight. So when the exam is, when you come to the clinical exams, don't worry about your theory. You only need to focus on your day-to-day clinical practice. Shall we move to the next slide? Yes, I think I have put these points. I have 10 points, 10 sentences, 10 words basically. And I try to put that on the priority order. Why somebody is failing these clinical exams. I think the biggest point is the confidence. Many candidates think that they don't know. They forget they have been seeing hundreds of similar patients in their practice. And they forget they have seen many clinical materials. They have discussed many clinical cases. They are consultants among colleagues, and they have treated many patients. They completely forget. When they come to the clinical exam, they become very anxious and they're lacking in confidence, saying that I'm going to fail. That is the kind of cognition, negative cognition that you're having when you're coming to the clinical. You should take it opposite way. You need to see the other side of the coin, that you have been in the practice at least 2 years as a psychiatrist, and every time what you have seen in the patients that with the similar kind of presentation, what you come into the exam. So first you need to develop your own confidence. You should talk to yourself and see that how much you know, how many patients that you have seen, how many patients with schizophrenia you have seen, bipolar affective disorder you have seen, delusional disorder you have seen, OCD you have seen, PTSD you have seen, personal disorder, you have seen all of these cases. So you need to develop your own confidence that you can pass this exam. You should not have that fear, oh, I'm going to fail. Actually, failing, you creating by yourself, making you yourself let you down in the confidence. And also you shouldn't have any doubts about your knowledge. And you don't need not to worry, because thinking that this is going to be a big issue to tell this patient, it is general the same patients that you see in day to day. So the confidence is something that you need to keep in mind, and always have this positive attitude, positive cognition, and the confidence that you know. Because what I can tell in my own observation in the exam, I think all the candidates can pass this exam, clinical exam. All the people have that skills and competencies to present a case, whether it's a short case or long case or PMP. But what is obstructing them to come across to as a good candidate, because of their lacking the confidence of them. Because ask from yourself, actually, when you are going to the exam, in your mindset, do you think that you are going to, this is I can do this attitude? Oh my God, what's going to happen kind of. I think you need to change that mindset, that this you can pass, because you have the skills, you have the competencies, you have seen many number of patients in similar caliber. When you as an examiner, many examiners will agree with me, you can see the passing candidate. Something happened to the screen. Yeah. Hello. Is something else in the, appearing in the screen?
Chamara.
Yeah, okay. It's fine. Now it's okay. So you can see when you are walking in to the examination room, interview room, you can see the candidate's confidence. You can see actually who is the passing candidate and who is anxious. And having lots of papers in hand, and it's all get mixed up. And sometimes when you're walking, you having this kind of, and sitting in the chair, you sit in the edge of the chair, and you can see the anxiety. And you can see how much lacking confidence of this candidate. So it's better you to have that awareness and say, have the positive attitude and relax and present the way you usually present, rather than getting very anxious about this. Also, what I have noticed is this happening especially in our part of the world, in the sense in the Asian countries, India, Sri Lanka, and because we write a lot. Even the clinical case, we write, I have seen candidates writing 2-3 pages about the long case. But you are seeing the patient and going to present another half an hour within 10-15 minutes time. A lot of things can be in your memory rather than just writing down, because when the candidates need to leave the papers, and when you go through that, you can see that lots of unnecessary things, they are wasted their time just writing. What you need to do is this, again, I think it is because of the issue of confidence. That's why I think, oh, I might forget this, I might forget this one to tell. But if you get into the routine practice, rather writing everything, certainly you need a little bit of things in the paper just to follow the structure. Otherwise, I don't think that you need to write that. And what happened is, because of this issue, you write a lot, then you come there in your 15 minutes that you're given to present, you just kept on reading that. It doesn't give a good impression. It's not giving a good eye contact with the examiners, and you need to give it as a kind of you should be like a consultant material, giving your presentation from your head, more or less, because it's not a lot of information you need there, and have that kind of present rather than reading a paper. Automatically, as you are anxious, then you go into that mode without you knowing. So when you are practicing, practice without writing. You only write 2-3 things that you need to remember. Otherwise, just have do the presentation like a discussion with the examiners. So can you go to the next slide, Chamara? Yes, you all know this, the time management. Time management is a crucial in any exam. And it is a skill, and only way you can get it is through practice. When you are practicing, you need to practice exactly the way. It's no point of you are taking a history from a patient for assessment for 2 hours or 1.5 hours. You need to practice to get the things from the patient within 40 minutes for a 1-hour case. Then you have time, another 15 minutes to organize your thoughts about the management, about the investigation, and all these things. So the time management is extremely important. I have seen many candidates, they are very good, but they don't know how to manage the time. And then they fail because their salient parts, they cannot complete. When it comes to you are using your whole time, because it's up to the candidate to use the time given to you the way that you want. Examiners won't influence you to do this, do that, but they guide you to say that, okay, now move into a mental state examination, because not showing that you need to go there, otherwise you will not be able to complete the mental state examination. So make sure when you are doing the assessment, you should learn, you need to develop the skill to finish the taking the history, and while taking the history, you are doing MSc anyway, to complete the case within 40 minutes. Would you agree? And then you have 15-20 minutes you to put your own thoughts together. what happened is you use unnecessary time there, long time, and you have 5 minutes to organize your thoughts, and then you are walking to the examination room, to the interview room with the examiners without your thoughts are being organized, and it's all the places everywhere, and you mess it up in that way. So when you are practicing, always practice, even day-to-day routine practice, I don't know whether it is possible there, because as you have many number of patients, to get the assessment done within 40 minutes, because you only need the essential things there for the exam, because you are not expected to give the exact diagnosis or give the exact management. You are only presenting with the available information to you at that particular time. So time management is extremely important in assessment, and also when you are presenting. When you are presenting, you should be able to, you have 15 minutes, isn't it? In that 15 minutes, within 10 minutes, you should be able to do the up to the mental, it's even less than 10 minutes, 7 minutes, you should be able to come to the mental state examination level. Because mental state examination, history take 50% and mental state examination take 50%, because those two need to be balanced. Some people have a very good history and little mental state examination. 80% of time used for the history and only 20% for the mental state examination. It won't work, then it's not going to work well. So you need to make it balanced 50-50, because examiners would like to see your skills of taking a history and abstract the essential kind of stuff for that case, leaving the unnecessary things out. And then they really like to see your competency of doing a mental state examination and presenting the psychopathology. So my advice is, I think it should be 50-50. And then rest of the 15 minutes, when the long case examination, it's in examiner's hand. But again, you need to know, when you ask, you need to go very kind of crisp way, this is what I'm going to do, rather than vague and very ambivalent. As you know your stuff, you can just put it across. And remember, always don't waste time. If examiner asks something, that examiner's always trying to help you if you are going in the wrong direction. They never wanted to put you down and put you into a wrong direction. They always ask, then think in a split second, something going wrong somewhere. So think again whether you are get the examiner the clue from the examiner why he's asking this question at this time. So I can give you some the examples later. So the other thing is the time management. Long case time management is different to short cases. The short cases need to apply in the different method, and PMPs differently. We'll come to that one. So the time management is the crucial point. Some people just lost the case because of they don't know how to manage the time. Sometimes as examiners, we try to guide, but still they are not developed that skills and the competency to use the time appropriately. It is not that important giving all the information. What you need to do is use the essential information and do that part and use your time to the best of your ability. The other point I wanted to mention here is the time is the scoring machine there. Because every sentence you talk need to have some sense, need to get the score out of that. Otherwise, if it is irrelevant, just leave it. If you are not getting, if it is not relevant to this particular case or to the management, then you can leave it behind, because you are presenting a summary, not the whole case in that sense. Okay. Is there any questions there? No? Okay. can we move on? Yeah. So this is somewhat similar to what I have said, because in clinical exam, you have three clinical the settings. One is the long case, then two short cases, and two patient management problems. So in this situation, your approach, again, you need to practice your you need to practice this one three different ways. Because sometimes what candidates do is they are using the same approach that you have for long case for the short case. It's not going to work like that, because short case your approach should be different. You have a small amount of time and then you can get the best out of it. And long case, in some sense, long cases, handling a long case is easier in some sense, because you have a bigger time period and also you have a bigger arena to play. If you are asking the differential diagnosis, you can tell any number of differential diagnoses you want, and you have time to get into the various the micro details in the essential areas. But in short case, it's different. Short case is more different skill. You just capture what's happening very quickly. And also in the short case, we can see your the interviewing skills, etc., and whether you can crack the point in exactly the difficulty, the problem patient is having. Say in short cases, in my view, they have a lot of clues there. You need to take that clues and get into the track very quickly. Because if it is the many short cases can be personal disorders or alcohol or drug addiction or delusional disorders or PTSD. First couple of minutes, if you are a smart, clever candidate, first 2-3 minutes, the first 2 minutes, you know what is this about. So then you can go into exactly in that track, rather beating around the bush, I think, in short cases. PMP, patient management problem, it is another different scenarios they are testing, because in these three settings, they are testing three different clinical situations. Long case, you have time, you can get the complex one, and short case, you quickly, whether you can grasp exactly the problem is and can't get into the management. And PMP is mostly, it is your analytical kind of skill they are testing, because in PMPs, I don't think there is a right or wrong answer in some sense, as far as you can rationalize your answer and you rationalize your thinking. It is more analytical aspect in the PMPs they are looking for. Again, in the PMP, as a time is very limited, you need to come to the point very quickly. So my message is three scenarios. It should be a three type of skills and competencies testing, and you need to have a three type of approach. To move to the next. Yes, this, I think you may have heard this 100 times. Whenever you come to the exam settings, your common sense go out of window. And you think in your mind that they are looking for a very complicated thing. So it is not the case. So you always remember because when you are anxious, this is what happened. I'll give you a good example. Actually happened in last exam, I think. Yes, there was a patient who left the wife and gone and stayed with the mother for last 3 months. And the candidate has taken a good history. Now the patient is in mother's house, but never asked why you have left the wife. I think in the day-to-day setting, if you meet somebody, over a cup of coffee or tea, if you mention that, oh, that guy has now left the wife and staying with the mother, first question he asks us, why he has left. So that is a common question that we raise. But in the exam settings, you sometimes move out of from common sense, and you think that the diagnosis is the main aspect and we need to see what it is, and you are just going for the diagnostic criteria and all, rather seeing that why this has happened in the first place. I can remember when I was the candidate at that time, Professor Nalaka Mendes was the only professor, I think, at that time. No, there's another professor in Jaffna. And we always wanted to present to the Professor Mendes to learn how to pass the exam. And my contemporaries know about this story. I took a case from Galle. I was working in Galle at that time, and it took 3-4 hours to come from Galle to Colombo, PGIM, and came with the patient and all these things. And he only listened to my story 10 minutes and said that, no, this nonsense. And I was so demoralized. One thing he asked was, it took me a long time, even after passing the exam and after getting after practicing many years, then only it came to my mind. The question he asked was why this person became ill at this time. So it was a very good point, but when I was a candidate, I couldn't get that. But that day I learned, this is what, because he gave, then after that, a couple of days later, he gave me a ring and said, this is what I made, because if you are going to present like that, however effort that you make, you are going to fail, because you need to see, you need to focus on the common sense. Why this particular person getting unwell at this particular time? It's not that they are interested, this patient is having schizophrenia, this patient is having bipolar. Why he has developed the symptoms at this time? It's always keep it in mind. In the clinical exams, always need to find us what is the trigger, why at this time, that they wanted to know. Even though it is, when you talk about that, you feel okay, but it's really to get into the deep sense of it, you need to think 3-4 times. It's something I learned when I was a candidate, that you need to think about why he's getting unwell at this particular time, rather just trying to dig into what the diagnosis and how can I manage that one. So for that purpose, you need the common sense. You always keep the common sense, keep your eyes open, keep your ears open. But you use your common sense usually when you're taking history in your ward patient, if it's not exam setting. When it's an exam setting, only this thing happen because you think there are many other expectations of this one, and then you forget the basics in some sense. Okay, shall we move to the next one? So this again, even though it is simple, these are the simple reasons people getting the fail. It's not because they don't have a knowledge or skills or competencies. Common diagnoses are common, and this is the word by the common things are common and rare things are rare. In clinical scenarios, even though it's a rare condition, you always need to give a differential diagnosis, because in clinical situations, you have only little information in some sense, because you have only the information given by the patient at that particular time within that 40 or 50 minutes period. And patient may not give you all the information. It depends on the patient's mood, and he has. So it is, you have actually little information in that way. So you can't actually arrive at a diagnosis in a clinical exam. You are not expected to come into the definite diagnosis. It's always, it should be differential diagnosis, because there are various different, information that you are missing there. You don't have in hand. So it could be various other conditions. I think few candidates just given only one diagnosis. This is it. I'm talking about the long cases again. Short cases, you may be able to give the diagnosis because there are a lot of clues there within in the patient. But long cases, always it's a differential diagnosis because there are lots of unknown quantity, and also need to come for the common diagnosis. Actually, end of the day, compared to other field of medicine, in psychiatry, what are the cases that they can give? Psychosis, it is schizophrenia or bipolar affective disorder. They either have mania with psychotic symptoms, depression with psychotic symptoms, and psychotic depression, delusional disorder, probably EUPD with some psychotic symptoms, and then OCD, PTSD, and generalized anxiety. Those are the conditions you can get. I don't think you can go beyond that. There may be cases out of that area, but we need a lot of information to come into the rare diagnosis. So all the cases need to fit into this common diagnostic settings. And remember, always give differential diagnosis because you have only limited information at that time. Shall we move to the next one? Yes, this is the one I wanted to emphasize more. What is the purpose of assessment? Exam setting or any settings. In the exam setting, again, what we are testing is your skills and competencies of assessment and presenting something and how you are going to manage. So purpose of assessment is to arrive at a diagnosis. And then in the exam settings, you presenting it to somebody who has not seen the patient, only with the salient facts, the other party, examiners, to get their thoughts correct and see whether this candidate's diagnosis is compatible with the information that they have given. True that examiners are having some information given by about the patient, but it need not to be. Examiners never check whether this candidate has taken all the informations that they are given to us, because to make that paper, that information gathering, they take 2-3 hours, but you are given only 45 minutes. So you only need the salient, important, significant things there, rather than all the the details. So the purpose of assessment always to build up the case, and in the history of the presenting complaint, and then rest of the things to substantiate your information to arrive at diagnosis. And then you are not doing a mental state examination separate, and the mental state examination is there to see at this time, at present, whether the patient is experiencing the psychopathology that you have told in the history. That's all it's about. And there are in worldwide, there is an agreement that when you are taking a history, doing the assessment, first is the introduction. You all know about it. But again, in the exam settings, you miss some of the things. As you know, whether it's how old the patient is, and whether the patient is married, single, whether they have a young kids, whether they are employed, if they are employed, what the employment was, and how is their living situation, living status, whether they are known to the services before. That's all. That is the introductory statement, which you take only 1 minute, which give a very good impression to the examiners that you know how to take the case. But many of the candidates, even that introductory statement, they miss some of the things, especially the job that patient is doing. It is extremely important in the management or arrive at a diagnosis sometimes. So those kind of things it's a bread and butter. You shouldn't miss anything in the introductory statement, history of presenting the patient's complaint and history of present feeling illness. And then the rest of the things, family history, personal history, all these things are only you need to mention what is relevant. It's no point of telling that he has gone to this school, then been to that school, and he has done this, that. But if it is relevant only, because otherwise you are just using your time, but you are not scoring. It is in 2020 match, you are not just blocking the ball, but not hitting 4s or 6s or not scoring. So you need to learn, only you mention, use your time where you can score. And then you should not miss any kind of headings like premorbid personality or forensic history. At least you need to briefly mention some of the things there. Otherwise, the examiner's head, what we get is this candidate has completely missed this part. Probably patient might not have any forensic the problem, but you need to mention that there is no involvement with the police or something to give the impression that you have asked about it. And then another thing I have noticed is people are very good in taking a history, long histories, and then finding difficult to present within the limited times, get the salient facts there. You only need to present the summary of the things. And then their mental state become very small. Actually, mental state, you need to spend a fair amount of time, because that is the place examiners test your skills and competencies about the psychopathology, and also how good you are to abstract and demonstrate the psychopathology of the patient. That is the main important point, because information gathering anyone can do, I think, if you have some knowledge. But mental state examination is the psychiatrist's main job, doing a good mental state examination. Again, there is a standard on mental state examination: appearance and behavior, speech, mood, affect, thought, orientation, insight. Don't miss any of these things. You need to just have a brief point there, because many candidates I can remember, when they finish their time is gone, when they are only mentioned about the appearance and behavior. Rest of the things even they couldn't tell. So try that's I mentioned in the timing. So give a good emphasis on psychopathology. It is very, very important. If it is patient with schizophrenia, we should say, in that case, you all know first rank symptoms, and every first rank symptoms, whether it is there or not, you should mention in the mental state examination in the clinical setting. So that is what expected. That's why you expand the mental state. If somebody is having auditory hallucinations, then you need to go into town with that. You need to mention every and each things, whether there is command hallucination, whether there is no command hallucination. You should mention whether there is thought echo, thought insertion, thought withdrawal, all these. Sorry, the second person auditory hallucination or third person command, all these things mentioned. If there is having a one delusion, then you need to mention about everything. Even it is not there, you need to show that you have asked about this. That's why there are the thought insertion, thought withdrawal, thought broadcasting, all these things you need to mention. In one sentence you can mention, because sometimes patient might have that. If you don't ask it, they won't just volunteer that information. I think many candidates, difficulty is not getting the history. Difficulty is presenting the relevant part of it and doing the mental state examination. So those keep the vigilant about that. Can you move to the next one? This is another thing. Understand what management means. Because usually examiners, okay, doctor, tell about the management. then you need to know, you should not forget the basics of the management. Where are you going to manage this patient? The first step, whether patient you are going to manage inpatient or whether patient is going to manage outpatient clinic, and then why. You need to give the answer. You need to give the rationale why you have made that decision. Then you can impress the examiner. Then you can, examiner knows you are an experienced psychiatrist. You have dealt with these kind of situations. Say, as an example, if somebody is having persecutory delusional beliefs about the neighbor, it's a race. And if he's living alone, there's another race. In that situation, you need to tell, I wanted to manage this patient in the inpatient setting, at least initially, because patient is living alone and he having these kind of thoughts, he can act on this. In that, as there is a risk, in that case, I want to manage this patient as an inpatient. Or sometimes you might have a case, you have a very inconclusive, you cannot go anywhere, it's a two differential diagnosis. Then you can tell, I wanted to manage this patient as inpatient setting for more observation need to make, to come at a diagnosis and then manage. Otherwise, you can say that if patient is coming far away sometimes and you don't need to inpatient, then you can say that in this patient, it looks like risks are very minimal in some sense, and we can manage the patient in the outpatient clinic. So first step is where you're going to manage the patient. Second thing is investigation. Many candidates are very good to mention about the blood investigation. And they say just blood investigations and all, but again, you need to expand what you're going to do and why. And forget the social investigation, because you have only interviewed the patient. You have never interviewed the parents or the family members or friends or anyone. So you need to get that collateral information. Every and each patient, it is a must. Otherwise, you may be barking the wrong tree. So you need to admit the patient or whatever, and you need to get the collateral information. They forget that. Many candidates forget. Even you giving the prompts, what else you would do, what other investigate, still they completely forget. They go to the MRI scan and CT scans and all these things, EEGs, rather talking to the family. So remember about that. Investigation means social investigation, physical investigation, and psychological investigations. If you can say that you might not have a psychologist, or so you can say that if I have opportunity to have a psychologist, I will get the psychological assessment of this patient. That's an investigation. So where you manage the patient, investigation, and then move into the management. Don't wait until, okay, what you are doing next, Then the examiner is become you are not getting the credit of your skills and competencies you already have when waiting, asking the next question. Just move into, then the examiner can see that you know where a patient is managing. Now we have done the investigation. Now you are going to the management, in the sense the pharmacological management, social management, and psychological management. Many people, sometimes candidates thinks I need to mention about the drug. You are, because you are the person who is managing the case. You can manage the patient whatever the way that you want, if you can give a good the rationale of your management, because the management is at that particular time what is appropriate for the patient and what is necessary and what is relevant. Those are the three things that you need to think about, and then it is in your hand what is the way that you manage. There may be cases, if you are not sure, I will rather observe the patient for first 2-3 days to get exactly what direction I need to go for, rather starting antipsychotic straight away. And also the other thing is, always, it is most of the time is a pharmacological management come as the first line, but there may be cases psychological management may be the first line and the pharmacological management may be the second line. Or some cases, the social management may be the first line. So you can think which one is the priority. And then when you are mentioning about the management, complete the sentence, complete the whole thing. You can't just stop saying I'll start antipsychotic. No, I would like to start antipsychotic in this particular patient. I think it's better me to start olanzapine because patient is not sleeping and has a clear, strong psychotic symptoms. And I would start with a 5 milligram, and then gradually I will titrate according to the response. Then it gives a very good impression that you are telling everything rather than asking what dose, what this is. And there you can go either yourself, you can say that if patient is not responded, and this is what I'm going to do, and manage the whole case. Okay, can we move to the next one? Yeah, this is my last slide, I think, the 10th point. Deal with what is in front of you, not assume things, because the patient who is given to you, the available information, that is what you are going to deal with. And don't have many ifs. If this is this, I do this. If this is no, then you are assuming things. In this particular patient, who in front of you, you manage that one. But in the management, you can ask, you can tell the examiners, I need this information me to manage. Rather assuming things, always what in hand, what in front of you, what information you have, and what are the informations you are going to get. Depending on that, you are managing. Rather, you assume going to go this way. I think those are the 10 points I gathered, which would be important for prevent failing. And then finally, just overall, what expecting is, whether it is a long case or short case or a PhD, it should be crisp, solid, clear, and nice wrap up. This is the way I do it. Okay, that's all I thought, and I can open it for any questions. I am aware, actually, there is nothing much. You all know these things, but the problem is, it's not that you knowing, you need to put this into the practice. That is the difficult part. Because especially in the exam setting, you all may have heard about 100 times, but the thing is, need to learn how to put into the practice. Okay. Questions or contribution, any views?
Yeah, thank you very much. I think it was very interesting and very important, and I think all the candidates would have benefited from it. Can you please tell us now from your, can you just brief us about the plus points or the good things that you observe in a Sri Lankan candidate, and then go on to the deficiencies, if possible?
Okay. Actually, yes, it's a good question, because I just focused this one to give that how to prevent failing. Actually, your candidate, the last exam, because I was examining here, I wouldn't compare if the MRC Psych CASC exam is similar to the MD, because MD is a degree, MRC Psych is not a degree, but candidates are here, the CASC exam, it is 3 years. Yours, it is MD exam, generally, I think 3 years. But the biggest positive point I have seen is our candidates in the MD, they have a very good knowledge, big knowledge about the conditions, about the medicine, about the actions and everything. But sometimes it might go against you in the clinical situations, because when you know too much, in the clinical case, then you can't fit in all these things into within 15 minutes. One good, the one positive thing I found was it is candidates are having a good knowledge about the case, and many of them, I think in my time last year, 80% passed, 80 or 70%, because we couldn't fail people. Actually, they were doing very well. And their presentation, actually, if you compare to my time, nowadays candidates are far ahead than our time, because they are the presentation skills and their confidence and their the management, all these things are good points actually, and people are more can have a discussion with the examiner in a kind of same level. Knowledge is the main thing I saw, and even the many candidates are very good, excellent. I think many I know that only one gold medal, but many people have scored to the 70s, don't they? So that is good. And some they are. The other thing is, what you can see is people who are doing well in all areas, short cases, the long cases, and PMPs, because they know the art. I think they have learned the art of presenting and abstracting psychopathology. I think that arriving at the diagnostic skills are very good. People have a good except very few. Many of them arrive at a reasonable diagnosis and giving cases for and against. And I think they have had a good practice in the previous bunch, probably because they had good time as well, because COVID was there at that time. So you can't do anything else apart from studying and practicing and all, I think. But you can see they had a good practice of presenting a long case, presenting a short case, and a PMP. Does it answer the question, Gyan?
Yeah. Thank you very much. And the major setbacks or major problems are candidates when compared to the British ones, or the negative points. Was language a problem?
I don't think so, except very few. I don't think language is a problem at all, because they can present very well. I think if you ask, the failure point is, one point is some people stick to their guns in a wrong the footing. So as an example, if somebody diagnoses something and they are not shifting from that at all, even you give many kind of clues, think outside the box. If it is not this one, which it could be, kind of thing. Some candidates used to stick to their only the 3 or 4 given only one diagnosis in long case, which is not possible, not practical. And also when you're getting anything else, you need to have at least 3 diagnoses. No, it's even ICD-10, the mental health diagnosis, they say that you only can diagnose a mental illness after organic conditions are being excluded. So any case, every and each case, even organic situations are distant possibility. So you need to have a think outside the box. One thing I see is the rigidity. They are sometimes very rigid. No, this is it. It cannot be anything else, kind of. So, and another thing I got is actually the exams here is very funny, task exam, because there is no interaction, isn't it? But there are in MD, when examiner tells you something, I don't think any examiner pointing you to a wrong direction. Always try to put back into the track. So trust them. Sometimes some candidates think that, oh, they are going to put into a trap. It is not. Always they say that some to get into the track, trying to pass, not to fail. But they themselves keep on not coming out from that mess, even after rope is given. Okay.
Yes, sir.
And do you think that the candidates concentrate more on pharmacological management and do not explore much about the psychosocial management aspects?
That is true, actually, yes. They are excellent in pharmacology, but they automatically, it won't go into the other social management and psychological management, because I think you have some psychologists now, don't you?
Yeah, we do.
Yeah, and even you don't have a psychologist, you yourself has some supportive psychotherapy or whatever you call it. You should not forget that completely.
Sajivan had a question. Sajivan?
Hi, Sajid.
A question, a comment, sir. Thank you very much, sir. On behalf of the Board of Study, I would like to thank you for taking the time and giving the feedback.
Pleasure.
So I think you made very important points, sir, about this, the need, about the fact that the clinicals are just replicating your clinical practice, and that's what we are looking at. And I think many candidates overthink, and then they try to impress the examiners with a lot of theory, and then they come out with very artificial management plans.
Exactly.
Yeah, I think that we can remember, Gihan, we had the Australian exam in the previous year, and she said that some of our management plans are not practical even in Australia. So they were so sophisticated management plans. So I think just if you take it as part of your day-to-day, just replicate your day-to-day clinical work, which I think our candidates are very good at, isn't it? Our clinic. So that I think so. You made a very important point, sir.
Yeah, of course. That's what I trying to make it, because clinical exams, I don't think you need to do the different thing. You need to exactly do what you are doing in your ward settings. So, but having said that, in your ward setting, you need to improve your day-to-day practice and at least come to the standard kind of level.
Yeah,
because
I think now we do have the time now. Even at Angoda now, things are not that. I mean, they can easily see the new patients or new admissions for 40 minutes. I think.
Exactly.
We can. I mean, our clinics and wards are not as heavy as it used to be, because now psychiatric services are available all over the country, and we can at least at Angoda, and I think even at the the university units in Colombo and Kaluboville, I think things are not that heavy. They can easily spend 40 minutes.
Yes.
Like there are some centers which are heavy, but okay.
Yeah, still at least once a week you can do. They take the kind of 40 minutes and do that. I think your routine practice which you need to replicate. Otherwise, you can see that whether this is an artificial kind of way you are doing only for the exams.
I'm Ajit.
Is it possible for me to ask a question? I'm Pushpa here, sir.
Yes.
Then I will ask later. Okay, go ahead, Fuspa.
Sorry. Is it okay?
Yes, please.
Yes,
Nice
sir.
to hear from you.
Sir, hi, sir. Sir, is it relevant for them to talk about psychological tools in the clinical exam, that they are supporting the clinical examination with the psychological tools? Is it a necessary thing to say or not necessary?
It depends. Say if it is a case of, it depends how relevant it is. In my case, my view.
Okay.
Say if it's a PTSD, I would certainly go for a psychological approach, and we can use some of psychological tools in that sense. Even depression.
Yeah.
You can. I don't know whether you are using tools or not.
Sometimes we ask the trainees to use the psychological tools, because we are not having the psychologists, so that we can properly monitor the symptoms. If it is negative symptoms of schizophrenia, that sort of thing. So the trainee will be doing that, though the psychologist is not there.
Yes, that is very good. Actually, say BPRS, all these things you can practice. Right. Because actually problem is, if you are actually not never seen a BPRS scale and just coming and telling in the exam that I'm doing this is the problem. Because examiner knows whether this person is having at least seen
an
idea. But I won't say that I will do a personality assessment with the
definitely
kind of which I'm never going to do. But still, if if you are doing the management and if it's a case of complex PTSD or complex EUPD, then you can go to that level as well after passing, because I told you this
Yes.
standard
Yeah.
practice is the pass mark, benchmark. And
Okay.
then you can score rest and saying that if it is if I'm still having the problem, then I'm doing the personality assessment. So it's not the wrong to mention that. I think it's quite right to mention that, because sometimes we do that. Now, even here, there are some cases. Even my ward yesterday, I sent one patient to getting a opinion from the Mosley. Still, we considered mostly as the mecca for psychosis. So you can tell that in this particular situation, I might get an opinion from another the person who is another colleague or whatever. These things can you do, and you should do that as well in your day-to-day setting. Not always, at least the complex cases, complicated cases.
Yes, that should not be very artificial. If it is the basic principles, basic things has to be done, and then they can talk about it.
At least you need to, you may have seen, if somebody shouldn't talk about ECT if they have never seen patient had the ECT. Simple as that.
Right.
That's how it is. That's how I see it. And
Thank you very much, sir.
Yeah.
Sir, can I come in? I'm Ajit Jaisega.
Ajit, yes.
Yeah, thank you very much, sir. And I hope that, if there were more examiners listening, it would be wonderful, because I don't know whether you have thought insertion, because you are just echoing my thoughts as well. I'm just saying the medical students that the final MBBS exam is very difficult to fail unless you want to fail, because it's very clinical that what we have been doing. Our registrars are very good in our wards. If they just replicate what they are doing in our wards in the exam, it is that is. That it's what it is. But what they think is the exam is something very exotic, completely not related to whatever they are doing in the exams, and they're trying very hard to do something extraordinary. That
exactly
might be one problem. Yes, I agree 100% whatever you have told, and I have been the examiners for a few years, but I'm not very expert. But I completely agree with you. My message for the trainees is that do your clinical work well in the sense that whatever the way that you can do optimal, and you have 3 years of clinical training, and just do the things that you do best in the clinical work. Just think that this patient is just one of your patient that you have got in your routine clinic, and just make the management plan. Then you will be
correct.
okay. Thank you.
Exactly. And another thing I want to mention is don't try to copy somebody else's presentation style. It's not going to work, even your consultant, because you only need to take the structure, because you born with your own style of presentation, but you can get everybody's good points and have a kind of system that you would do. Because another negative point, as Gihan asked, I forgot to mention that, because here the exam, people are not writing that much, and people just telling in like a discussion. In people, as I said, some people are writing a lot. Would you believe for that 40 minutes, some people have 10 pages, written 10 pages, double-sided. And then to read that 10 page, you take 15 minutes, and you cannot assess any of the things in that situation. So I think write less and talk more in clinicals. Okay, any other questions?
I think that the trainees should ask questions from Dr. Thilaka Ratnayake, especially who are sitting for the exam this time or who sat for the exam last time.
And when you are walking, walk with a smile, relax. Rather, the like mask face like you are on chlorpromazine 500 milligram. Just have a relaxed and nice emotions. Then it's make.
Yeah, one other thing that I'm noticing with our trainees is that I mean they don't think that we are equal. Or even now, they should be asking whatever the question that they are having in our mind, their mind. I think it may be again sort of a Asian culture. They don't think that we are equal. They think that we are in a sort of very higher up, and then they are very reluctant to approach us and ask questions. That's just a thought.
Yeah, actually, that is a cultural thing. Can you hear me?
Yes, we can.
Yeah, good old days, examiners were gods. Only there were few examiners, 4 or 5, so untouchable. So, but now it is more generalized because as you said, in the Western system anyway, there is very equal, and you make the tea for your trainee, and trainee sometimes make the tea for you, and it is a kind of equal partnership, and they openly discuss things. But now I think it is much better compared to before. In my view, anybody can become examiner if you have done the MD exam yourself and then practice couple of years in the hospital, the ward settings and whatever the settings, and then you can become examiner because you are actually compare what your standard practice and whether candidates doing the same thing. You don't need to have a massive knowledge to become an examiner, in my view. It might be counterproductive sometimes when the examiners knows a lot because they bring the theory into that one. And then it's become the theory assessment, knowledge assessment rather than clinical assessment in my perspective. That's why in the UK, now they are our exam system, you can sit the clinical exam without theory, anybody. So you can pass, some people have passed clinical exam CAS, but they haven't done the theory yet. So because that's why I want to emphasize this is two different things.
So that we actually balance the examiners, like we have an equal number of university academics as well as health ministry clinicians at the exam. That's something that we are doing. So that's something that we try to do every, and also like senior and junior also, like we have some always some new examiners every year now.
That's very good.
Yeah, and so you don't get only the seniors, even some of the juniors come for the clinicals, and the pair would be a very senior one with a someone a middle grade examiner, and so that kind of we try to balance these, and also we try to introduce new examiners. So we have a larger pool of examiners rather than anyone who has 7 years experience can be a clinical examiner. So that's the PJM rule, 7 years post-board certification. That's the PJM, and we have got about 30-40 people or even 50 eligible now.
So, that's very good. That's very good. And the examiners, actually, we have had the discussion in the examination among the examiners. We shouldn't try to see what we practice. We need to see what is the standard practice. And that's what the candidate need to know. Candidate need not to follow the examiners and say that, oh, what that examiner is doing, what that examiner is prescribed, but it's immaterial. It should be a standard practice.
Yeah. And also, so examiner training and trainer training is done at PJM formally, and also we also have our own things as you but the PJM is also doing it very formal, trainer training and examiner training. You can't become an examiner without the training.
Yeah, so, I have attended a couple of the sessions. It's very good.
Yeah,
making it standardized.
Yeah,
that's why this is all positive factors for the candidates. So candidate need not to worry.
Yeah.
If you are a good doctor, good psychiatrist, then clinical exam is just piece of cake. If you don't mess around. Anything else?
Yes, Dr. Jayasekara quite just pointed out, we are still waiting for a trainee to ask a question because all the examiners are voicing their concerns, but not the trainees.
And I think, I think the trainee should ask questions, right? At least one.
Because this is for them, not for us mainly.
We have adopted a system here. Actually, recently we have done that in our teaching sessions, teaching programs. The consultant shouldn't come first. Always trainees need to ask questions. After that, only we given the opportunity for SPRs and then the consultant. Because otherwise, the trainees keep quiet. That is another thing that you can observe that itself. It is the confidence again. And trainee might think, should I ask this or shouldn't I ask this? Kind of ambivalence. You shouldn't, you don't need to be. You can ask any stupid question when you are a trainee. But when you become a consultant, you can't ask that kind of question. Now you are free to ask anything. That's why I always say that a trainee job is the best job because you can do anything. But when you become a consultant, you need to be, before asking the question, you need to think twice whether I should ask that or not. But trainee, whatever comes to your mind, you can ask, like rather any hesitancy.
Please don't think that you will be judged by the questions that you ask.
Yeah.
That you ask the examiners. Yeah, we will not judge you or laugh at the questions.
Hello, sir. I'm a third year registrar here, Chaturani. I would like to just thank you for your presentation. It was actually quite crisp and clear, hence maybe the absence of questions. You actually answered all my issues that I had also. So I don't really have a question, just I want to thank you for taking your time and doing the presentation.
Oh, it's my pleasure.
So this is Jayanta, one registrar here.
Yes, Jayanta.
So now, what about the, let's say, like PMPs? What is the impression that you got out of PMPs, candidates' performance, and then what's the sort of way to get around? And is there any advice that you could give, sir?
Yes,
on PMP?
Yes. In my view, please correct me if I am wrong. The examiners who is there, my view, the PMP is there just to assess your skills and competencies when there is a problem in front of you, how to get a quick kind of the rational answer and your analytic ability in that particular. They are actually more, when it comes to the PMP, it is more than clinicals, it is situations. So in that situation, how would you react? Because there are situations which can happen when you are a consultant, or when you are a specialist registrar. Suddenly something might happen, but you can't go and discuss about this and come back. You need to give the split-second answer to that. Say, as an example, if I'll tell you, it's not as an example, if you treat one of your patients and then patient is angry, patient's husband is very angry with you, and he's waiting outside, I'm just creating one, outside the door, when you are finished your work and going out. So what you would do? That kind of thing. Or you see that your consultant is doing something wrong, it is not the good practice, not the standard practice. How would you tackle that? Or say you have the Minister of Parliament, MP, or a minister coming and telling you that this is the patient who he knows, and please do this, that, and that, and how would you deal with that? That kind of situation. Actually, there is no right or wrong answers in my the idea in the PMPs. It is your analysis and how would you react and what is your rationality. Is that right? Any examiners? PMPs specifically.
Yes, and also they check some of the aspects that may be missed out in the clinicals, like ethics and things like that.
Yeah.
Some of the things that may not be tested in the clinicals, so they will also try test those.
The emergencies as well, which can't be tested in clinical situations.
Situations, yeah.
Yes, and then as you said, sir, this is analytical and maybe even say, I don't know whether it is ethical and whatever, that cannot be sort of, there is no, the places where there are a lot of gray area.
Gray, exactly. Gray area, and then there is no right or wrong answer as far
Yes.
as you have a rationale behind what you're thinking.
Yes.
And also the circumstances. Now, say if somebody acutely the unwell coming to your ward suddenly become acutely unwell is different. If you are in a railway station and you see somebody suddenly getting acutely psychotic and you are a psychiatrist, in that situation, what is the way that you might deal with? If he's become aggressive, hostile, attacking people, then you might, it's different. In different scenario, there may be police involvement, and you might be able to contact somebody who is a social worker or something like that, I think. There is no right or wrong answer or fixed answer for PMPs. And PMPs, that's why PMPs are keep on changing. It's from we can create PMPs easily. But many of them are actual situations happen in different part of the country, and consultants are bringing that. And they themselves were not sure exactly what to do in that situation, but later they realized this is what needs to happen. And then you need to take the decisions. You need to make decisions, but you have given very limited time to make that decision. So it can be at that particular time, that would be the best that you can do. It may not be the right thing though. You with me? So it's an analytical ability, more or less. As for message for candidates is in PMPs, there is no exact answer. You can think at that time when you heard that, and every word in the PMP has a value, and very focused on that and why they have put that one. And depend on your decision, depend on that. Say if it's a 16-year-old, 45-year-old, 70-year-old, similar presentation, 3 different answers. So every word has a value in PMPs. Take into and then just have a rational way of dealing with that. It is not the knowledge. It is the, as somebody said, it's an ethical practice and things that you can't test otherwise. Anything else?
Thank you very much.
Sir, I'm Rajika, the third year registrar. Sir, I have got a question for you. So if the patient is exhausted after talking to many candidates, and if the patient doesn't give much information,
yes,
how can cope with the situation? And I want to know at that time how the examiner, what the examiner expects from us.
Hi, Rajika. Yes, it's a good question. Actually, we ourselves, I think I can't remember who was my co-examiner at that time, same patient. And when the first time comes, give a story. And actually, we have some format in front of us, taken by this PRs before. And then when second candidate comes, this man giving a completely different story. Because you can't completely rely what patient says, but at that particular time, what patients, that's what I meant by just deal with what in your hand. At that particular situation, patient tells you a story, and that is what you need to build your case on. So we are, as examiners, we are very well aware about that, because there is a big individual variation from the patient, from when you are talking to one candidate to another. I'm sure that examiners are aware about that. Actually, to remove that bias, that's why in the CASC exam here, they are using the role players. and they are exactly the same thing to the every candidate. But as we are using the real kind of patients, that's a very good thing, rather going for the role players. And that difficulty the candidate facing is taken into consideration. So in your point, your way, what you need to do is don't worry about what examiner is given. You can tell this is what the patient told me in my interview. That's it. And you build the case on that. It's so interesting because another problem with our patients, people who worked in Western countries may notice, the patients here are telling you a problem quite easily, openly. There is no hesitance. Our people, I think it's another cultural thing, going into circles, very circumstantial, rather telling the problem. He may have a problem with the wife, but he start completely different thing, and then coming there, it will take 4 or 5 minutes. So candidates having that difficulty because patients are very circumstantial.
I can give one example in the other way. Now, sometimes even in our final MBBS exams, the medical students have completely sort of elicited some sort of a psychopathology that all we have failed to elicit. And then even we go back to the patient and find out that is there, and we all have failed. The candidate had somehow managed to get it, and we credit for that.
Yes, it is the biggest skill that psychiatrists need to have, get the things. But I don't think that patients are given only twice or 3 times maximum. No? But patients...
Yes, yeah. I think I will have to explain that patients are given patients are given usually only about twice, right? And that's also only very good patients.
Yeah.
Certain patients, we won't repeat it.
But I have observed that same patient, so it was a short case actually, same patient giving a completely different story to the second candidate. But it is nothing going against the candidate because we hear that story. And I think nothing go against candidate but not getting some information. If you have the major information and then the information in your hand, you deal with it. But you cannot miss a major chunk, I think.
Sorry, sir, I went out, my internet went out, but actually just wanted to explain that we actually, the coordinators keep a very close tab on the candidates. So there are consultant psychiatrists who are coordinating the exam. So if there is an issue, you can immediately tell the coordinator, and they are even, they have the authority even to change the patient. So, and we vet the patients very closely, and only the very good ones are repeated. Sometimes if the patient is not very good, we don't repeat it. So, I mean, it's, we try to minimize, I mean, there can be issues, we try to minimize it as much as possible, these problems with the patients. Okay.
And to add to what Sajivana just told, I think it's best that the candidates remember that if they are finding it difficult to deal with the patient, it's best that they inform the coordinator within the first 10 minutes to change the patient, rather than waiting for half an hour and then telling that, please change my patient, he's not giving good history. So if they tell the coordinator within the first 10 minutes, they can be changed because we have reserved patients.
Other things say that now we had a huge problem last time with the number of candidates, because there was 36 candidates and there was a large failure, and luckily the pass rate was so high last time, so that it won't be a problem next time. So we had a huge backlog of candidates, so it was a real challenge to get the patients for that. But even that, so next time probably the numbers would be less. Okay.
Now, if there's a problem with the patient, that is what we expect. Now, patient with psychiatric problems may not be cooperative all the times. If you find that problem, that is one thing that we expect as well. And you don't have to worry about the cooperation of the patients and that sort of things. If you find any difficulties, then you can explain that that difficulty, and it is sort of a real world scenario.
Yeah, when you mention about this passing, actually, I heard some comments that, oh, it is too many people have been passed and the exam standards are gone low. It is not the case, definitely not. Because what I see is whether I would take the candidate as a SPR in my vote. That is the benchmark. Actually, people in exams, you can't. All the candidates cannot be failed in exam. In that case, there is a problem with the exam. But all the candidates can pass exam. If all are reaching the benchmark, then all can be passed. There is nothing to say that no, everybody shouldn't be passed. But what I know in the past, people sometimes for 1 point of we call killer points. No, another thing that people say is if you don't kill the patient, then you shouldn't have a bad failure because 1 point shouldn't fail someone. But in the past, I know sometimes what happens is if there is somebody who's making a little mistake and and then it is not a somebody to fail the exam. I don't think standards has become lower. I think candidates have performance are better. All of any of these candidates, if we have set cast, they will pass. If you know the art of it and the other thing is now, if you could remember long ago in the clinical exam, here the cascade exam pass rate was even 20%, 30% sometimes. Now the pass rate is 80%. Candidates are performing better. They know the exam. They know what the expectations are. In the beginning, failure rate was high because candidates didn't know what expectations are. And even examiners didn't know how much, what to, and now the pass rate is 70%, 80%.
And I think another difference, I think in our local exams during our time, the examiners really didn't know much about the patient. And now the examiners very carefully see the patients. All the patients are seen by the examiners early morning and they are really well aware of what the patient is having.
That is true as well, because I can remember we saw the patient and sometimes what is in the transcript and when you see the patient, it is very different. Sometimes patient won't tell some of the things. So that is a very good thing. Examiner has seen all the patients that they are dealing with.
And examiners reject some of the patients. If the patients are really not up to the mark, the examiners will tell not to put them. Okay.
Yeah. So that is all going as a positive things for the candidates. So that is the reason, because candidates' performance are better, getting better and better. So the pass rate, that's why the pass rate is getting high, I think.
So hope to see you again as examiners. Maybe next year, this year is supposed to be Australia's turn. This year is supposed to be Australia's turn, but we don't know whether we can get anyone from Australia. Yeah. So we always alternate between England and Australia.
Yeah, lovely to see you all as well, even if it's through Zoom.
Yeah.
Yeah, we can have you for the sessions and you can stay on for the exam because the sessions are in August, so the exam is in September.
And sir, today, Chamara had to very carefully concentrate on the lecture because he had to turn the slides today.
So sessions are in August and exam in September. Yeah, you're right.
Sessions are on the 6th, 7th and 8th of August. Exam starts on the 23rd of September. Sajivana may know better than me.
And then
19th.
19th of September.
The candidates know better than everybody the date. So anyway, we'll discuss with Shehan. I'll be meeting in we'll discuss.
Okay. Yeah. Another advice what I can give to the candidates are when they are presenting, I know the system is they always present to the examiners or consultant. Why not candidate present to a candidate, another candidate behaving like examiner? Then candidates know how the examiner can pick these things, what is not being said, what is not being done. So candidate can be the role play as examiner, 2 candidates, and 1 candidate can present. Then as a candidate, when you are role playing as examiner, you can see how the other people, when they are presenting, what are the mistakes that do, then you can avoid that mistake.
Yeah, that's a very good idea.
That is it, sir. That's
Yeah.
another thing I'm telling the medical students, that how would you feel when you examine the 15th candidate coming and saying the same nonsense?
Mm.
Whether you, how would you feel about the examiners? That's a very good suggestion, and thank you very much.
Mm. Actually,
Sorry,
this,
sir, I'm a third year registrar. Sorry, sir, is it okay to interrupt?
please do. Yeah.
Thank you, sir. Your presentation was a real eye-opener for us. I've got a small question, sir. Do we need to present evidence for each and every management plan that we give, sir, like, or else based on the clinical experience or what we have seen, can we present a management? Do we need to quote like researchers that have been done, latest ones, and support our management, sir?
I don't think that you need to quote the research and all until you can't build the case to the standard kind of level. After that, when the examiners know, now you have passed the bar of passing, then examiner wanted to give the higher marks, then the examiner might ask, what is the reason, what's the evidence that you have, the clozapine and amisulpride being used together? And then you can show off your knowledge. But same time, you can do that as well when you have a time, when you are managing. But having the telling about the quoting, all these things can do when you come to some level, because examiners get stuck. Sometimes after you passing the passing bar, then again the ball is in your hand, and then you can keep on betting. Like when Sanat Jayasuriya was in good form. So that comes after you build the case. If after you go beyond the passing by. Having said that, whenever you say the management, say as an example, if you say that I am going to use clozapine in this particular patient because they have used these different antipsychotics for this long period of time and the response wasn't good, it's no point me again trying another one. So in that case, I am going to use clozapine. Confidently, you can say that, because why you are using that particular medication and that. So say if you are using somebody aripiprazole, you can say that I'm using aripiprazole because already patient is obese and there is a family history of diabetes, then I favor to use aripiprazole in this particular patient. Why it came to your mind, this particular medication? Rather saying according to the nice guidelines and this guideline, that guideline, this is the one I'm going to, because you need to show, demonstrate your clinical experience there, why you are using that. You with me?
Yes, sir. Thank you very much, sir.
Actually,
yes,
when
I
you
got
are
the point, sir.
Yeah, when you are a candidate.
I totally agreed with you, sir.
Yeah, when you are a candidate, you know that the time, the examiner's reactions and all, now you have gone beyond the bar of passing, and then the rest. Then you can keep on betting.
Thank you, sir.
Anything else?
Hello, sir. I'm Isuru. I'm just a first year registrar, sir.
Okay. Yes, Isuru.
So now, is there any tips regarding the short cases, sir, how to approach? Because I have just finished my first 6 months, sir. So we have limited time, and what we try to do is we cover all the aspects, all the delusions and hallucinations, all that, sir. So sometimes it's difficult to find how to approach the short cases, sir. Any tips on that, sir?
The short cases, one second, to me to the short cases, you see the patient in front of the examiners.
Yes, sir.
For 15 minutes, they talk to the patient, and the next
the
15 minutes they present. Yeah.
Yeah. Yeah. When they are talking to the patient,
Yes,
you are
in front of the
talking
two
to the
examiners.
patient in front of the examiners, isn't it?
Yes, yes, yeah.
Yeah. Yes. I think, please, other examiners contribute if you have a different view. I think short cases, they choose the short case, which candidates keep within first 1 minute, 2 minutes, you know, where you need to concentrate on. Say, if somebody is having the injection sites and all these things, and you know that it is a case of the drugs, the drug usage, or somebody has symptoms of withdrawal, you know that it is a case of alcohol. Or if somebody has various cuts, burn marks, all these things, self-harm behaviors, you know that it is going through the EUPD, or and if there is a flashbacks and all, it is the PTSD, and they give several clues in the first instance. So it is quickly you can enter what is the problem, and then you can take it from there, rather than like long case going to the differential diagnosis, thinking outside the box. This is very focused on one thing. And what examiners are looking for, when you know that it's a case of illicit drug use, what are the salient questions that you need to ask? If you, when it is patient with first rank symptoms, then what is the things that the one says the same, what are the other symptoms you need to ask? How do you demonstrate eliciting a delusion or pathological jealousy, these kind of things. So you need to quickly get into the thing and made up your mind, this case is going this way, and then ask the relevant questions. I think that is the expectation in short case. Rather, think very much laterally.
I just give you one answer to your question, that all the first year registrars, and from that on, you will have a end of your appointment and assessment that is almost like a short case. What you do at the end of one of your clinical appointment, that is exactly, there are very few differences. Otherwise, it is almost like a short case. And then you will be having about experience of that maybe 6 or 7, maybe at least about 6 of that experience before you come into the final, come into the exam.
Yeah, another thing I can mention is, now I can remember the short cases, you are assessing your skills and competence in one aspect. As an example, there was a patient with mania, hypomania. Patient was keep on talking. So what we expect is candidate to control the interview and get what you want. So some candidates who are not skilled how to interrupt the patient, and then patient will talk for all 10 minutes. And you don't know when to stop. So that what they are testing is whether you have the skills and competence to control the interview and get whatever you want. Otherwise, patient keep on talking. So that kind of scenarios that you get in the short case.
Thank you, sir. Thank you very much, sir.
And the other thing I wanted to mention about this, the short cases, and when you are talking to the patient, just again talk to the patient like you talk to the patient in the ward, rather than creating an artificial kind of situation. Just have a nice standard discussion, then patient can open up. It is end of the day, what they try to see is whether you can, within short period of time, whether you can establish the rapport with the patient and let the patient open up and get the information, the information, whatever you require.
Thank you, sir.
Anything else anyone want to ask? And
the questions to Dr. Thilaka.
Sorry, say it again. And one more thing, if I mean, if I say, for the candidates, never think that there are tough examiners and good examiners. There is nothing like that. Don't forget who is the examiner. Just you do your part. And also, there is no difficult patients or easy patients. If the patient is difficult, it's easier to pass, because if the patient is difficult for examiner as well. If patient is easy, then everybody knows everything. Then you need to go into a kind of deep the levels, micro detail. So don't worry who is the examiner, and don't worry about that. You just do your part. And even the patient, if a patient is difficult patient or easy patient, there is nothing like that when it comes to the exams, I believe. You were saying something, Gihan.
No, I just wanted to see whether there are any other questions or comments.
Thank you, sir, for the last comment, and then don't try to adapt your presentation to the examiners. That I have observed sometimes, because sometimes the examiners' favorite topics and whatever it is, you try to adapt, and then it becomes very artificial. And we don't, we just leave behind our whatever pet topics when you come to the exams.
True.
I think that's a very good point, Ajit. Very good point, because sometimes they try to second guess what the examiner is thinking. They try to think, this examiner likes this particular medicine now. I think that is very, you might fall in trouble by doing that. Yeah. Okay.
Yeah. You do exactly what you do. If you are in Kurnagal Hospital, what the practice in Kurnagal Hospital, just do that. You can say that we have, even you can, when you are talking to the patient, you need to show that you have the experience. I have come across this kind of similar situations, and we have used this. That's it. Different areas, they may be using a different things, but it's okay. Just adapt to your practice. Don't worry about what examiner thinks and examiner's practice, because there are two examiners anyway. If the one examiner is particularly favoring that, the other examiner will say that no, it's not fair. So there won't be any unfairness happening to the candidate anyway. Nowadays, it was the case, I think, about 10 years back. Now I think it has nicely generalized, and it was much standard in that sense. End of the day,
candidates rotate. Candidates also rotate every 6 months, not like during your time. Candidates, they work at 6 different places.
Yeah.
So there I know. Yeah, that's also different.
Oh, you were talking about our time. It was actually even unimaginable nowadays, the candidates, because when we were in gold, we were in gold. Then if it is the chief examiner from Colombo, then it's a problem. And when the chief examiner from Kandy, then it is everybody thinks that, oh my God, it's the other time. But now it is much generalized. It's really good. Very much high standards in that sense.
Just one more observation, because I was sitting with a foreign examiner, not this last year, but previous year. What she was commenting on our candidates was that now most of our candidates, when asked about the psychological management, they used to give cut and paste answers from textbooks. And most of the candidates were telling that I will do CBT for this patient. And when the foreign examiner asked, okay, please tell me how you're going to do CBT for this patient, they will say that, okay, I will challenge the maladaptive automatic thoughts of this patient and suggest them to have alternative thoughts. Then the foreign examiner, okay, now tell me what you're going to do to this patient. What are the, so then they get stuck. So that was one of the observations that the foreign examiner very prominently highlighted, that don't give cut and paste answers from textbooks and just tailor the management to this particular patient and tell about what maladaptive thoughts of this particular patient that you're going to challenge and change. So that is probably even during the last exam, we observed this.
Yeah, actually candidates themselves learned at least to provide brief supportive psychotherapy, cognitive behavior therapy, this kind of, not a full scale, some understanding about that, at least to observe, saying one, then you can talk about that. Because otherwise it's very difficult if you have never seen something, never observed something, never done something, and telling in exam and getting into a kind of difficulty.
Yes. Okay, then shall we make it a day? If there are no other, yeah. Thank you very much again, Dr. Thilaka Ratnayake. I think I forgot to mention in your, when I introduced you to the audience, that you are also a tribunal doctor appointed by the Ministry of Justice and a second opinion appointed doctor from the Care Quality Commission in the UK. And also I forgot to mention that you have trained quite a lot of Sri Lankan psychiatrists. So given them opportunities for their foreign training. And if I am not mistaken, Dr. Chamara Vijayasinghe, Dr. Surangi Jayaratna, Dr. Sumanatissa, Dr. Vipula Vijayasiri, and Dr. Nilanta Balasurya, to name a few. I don't know whether there are any more that you have trained in Bedford. So yeah, I think
yeah, those are the ones. Hope they are doing well.
yeah, they are all doing very well, and they have all returned to Sri Lanka. Returned back from their foreign training, and they are doing a great service. And Chamara is our secretary of the college, and
actually,
and
they did a very good job as well. Still, our teams are talking about them. So how good they are.
Hope you will not get them back to the UK.
They are welcome at any time. They desperately
need them here.
We can solve the job
just
now.
to mention also.
I can solve the job with Chamara.
And also
here, and I can do Chamara's job there.
And I also forgot to mention that Dr. Thilaka Ratnayake has obtained the fellowship of the Sri Lankan College of Psychiatrists, which is a very rare opportunity for a Sri Lankan working abroad. And so thank you very much, because the small points, although you may think that they are small points, I think they go a long way. And the small points that you highlighted are very important in the clinical exams. I think it will be very beneficial for our candidates. And the words of wisdom that you have given us through your experience of being an examiner and being a clinician, I think will be very important to all of us, clinicians as well as examiners as well and candidates. And thank you very much for enlightening us on the clinical pearls regarding presenting with confidence, time management, and analyzing the facts in the PMPs, and also presenting the salient features, and particularly about social investigations. I think it's a very important thing that we all need to know about. Thank you again for the valuable feedback and sacrificing your Sunday afternoon for the benefit of the trainees as well as the examiners. Thanks a lot.
Thank you. Thank you very much for listening. Nice to see you all.
Hope to see you at our sessions and probably at our next exam.
Definitely.
As the external examiner. Thank you.
Okay, take care. Bye.